And I'm sure you all know the old classical triad, which was called as a Virchow's triad, given centuries back, and we were all taught in our pathology classes. The Virchow's triad said stasis of blood flow, endothelial injury, hypercoagulability were three factors which contributed to the formation of a thrombus and its related events and sequelae following that, and that was called as a Virchow's triad, which still holds good forever. And coming to venous thromboembolism in obstetrics, the risk of venous thromboembolism is increased 5 to 10-fold in pregnancy. Hypercoagulability of pregnancy persists for several weeks after delivery, and the greatest risk for venous thromboembolism is in the early postpartum period. A recent decline in the maternal deaths from venous thromboembolism can probably be attributed to the use of thromboprophylaxis in high-risk women. 1, 2, the screening methods have become quite clear, and the obstetricians and the surgeons or any physician all over the world are aware of an issue called venous thromboembolism, and there has been a lot of data, 1 and 2, public awareness has come into picture, and so that all would probably contribute to the decline in the maternal deaths from venous thromboembolism. In the absence of randomized controlled trials, there is no evidence for a complex clinical score for venous thromboembolism, though there are various scoring sheets available and scoring systems available, and all of them have been put to use with variable results, which we will see over the next few minutes as well. The risk assessment in the antenatal period for a patient for thromboprophylaxis is done on select criteria. The risk assessment is recommended early during pregnancy and again in the postpartum period. Let me just tell you again. If a risk scoring has been done during early pregnancy, we would repeat another scoring during postpartum because the risk factors could vary between the early pregnancy and the postpartum period. And so we need to do 2 risk assessments, one during the early antenatal period and then one during the postpartum period. The risk factors would include previous venous thromboembolism, family history of venous thromboembolism, hereditary thrombophilia, antiphospholipid syndrome, one which we are all fond of, and medical comorbidities, significant pregnancy complications, cesarean delivery, prolonged antepartum immobilization for whatever reason, clinical risk factors such as increased body mass index, obesity, and age more than 35 years, and parity more than or equal to 3. So all these would be put together, and we even have data supporting from the Cochrane database which came into, and you will see the risk scoring quite fast. Coming to the postpartum period, assess for major bleeding postpartum, PPH, resulting in a drop of the hemoglobin concentration of more than 2 grams per deciliter, or bleeding requiring a transfusion of at least 2 units of packed RBCs. Every woman should have a repeat VTE assessment after delivery, and prophylactic low molecular weight heparin may be restarted 6 to 12 hours post-delivery, or should be delayed if there is any evidence of bleeding from the surgical wound site. Warfarin, low molecular weight heparin, fondaparinux, and unfractionated heparin are safe to use in breastfeeding mothers. So if there is a need to change them to the fondaparinux and the unfractionated heparin, you may do so, or you can shift them to warfarin. The oral direct thrombin and factor Xa inhibitors should be avoided, and when we're switching over between heparin and warfarin, there need to be an overlap, and we need to probably maintain the INR around 2, though there are different opinions about it. So overlap warfarin and heparin and take over the warfarin and slowly stop heparin if required, whatever may be the heparin, whether it's low molecular weight heparin or unfractionated heparin.